She's conducted research on coenzyme Q10, lithium, glutathione deficiency in Parkinson's disease, and she's studying intranasal glutathione to see if this boosts brain glutathione and improves Parkinson's outcomes. And another very interesting line of work that she leads is her work in developing a Parkinson's screening tool, Park9, which uses dogs to identify the scent of Parkinson's disease from earwax. Very unique and interesting idea. She's the principal investigator of the CAM, C-A-M, Care and PD study, which is designed to identify the relationship between lifestyle choices and the risk of Parkinson's progression. As a naturopathic physician, she maintains a clinical practice at the Seattle Integrative Medicine and conducts research at the University of Washington and Bastyr University. She is widely recognized as a highly respected and sought after speaker on this topic with a very unique mix of expertise. And we're very lucky to have her here today to speak to us on nutrition and Parkinson's disease. So thank you, Laura.
Thank you, everybody, for the invitation to be here. I am honored to be invited to speak to this audience, and as you will see, pretty enthusiastic about the topic. This is my disclosure slide. Nothing that I am participating in here will be a part of today's talk. So the first thing that I want to communicate to all of you, whether we are talking about dietary modification or medicines, natural or pharmaceutical, before you dive into any new treatment regime, I would always like you to be aware of what it is that you are trying to accomplish. If you are trying to treat your symptoms, the treatment, the therapeutic may be different than if you are trying to slow Parkinson's disease progression. Already today, something came up where one of our speakers talked about how yogurt may be good for Parkinson's disease constipation. That's maybe true. The data I'm going to present to you is going to show that the more yogurt a person eats, the faster their disease progresses. And so for each thing that we talk about, it's not one size fits all. It's not really that simple. There isn't a food or a diet for Parkinson's disease. It's much more intricate than that. And where this really comes into play in terms of trying to decide on your goals, I know you're sitting there thinking, well, who doesn't want all of it? I want to decrease my symptoms and slow progression. But sometimes there are gives and takes. Some people may have, say you're 95 years old. I'm going to be less insistent that you invest in slowing progression than if you're 45 years old. If you're 45 years old, it is really, really important that you do everything you can to slow progression, because I want you to be around for the next 50 years and be in good shape. If you're 100 years old, kind of do whatever you want. You're not going to be around for the next 50 years to deal with the consequences. So that's where this comes into play. You are going to become more familiar with this slide, this rating scale as this talk goes on, but I just want to show you the difference between what slowing disease progression looks like versus treating symptoms. In this slide, this visual on the left is somebody whose symptoms improved for a little bit, but over time they went back to normal. We helped their symptoms, we didn't slow progression. In the slide on the right is somebody who I didn't do much for his symptoms. The changes we made did not impact his overall symptoms much at all, but over the last 7 years, he's had no progression. So this is kind of what I'm talking about in terms of knowing what you're getting into. So traditional epidemiologic studies suggest that over the course of one's life, in midlife, your 20s, your 30s, your 40s, the more red meat, processed meat, bologna, ham, deli meats, dairy, refined grains, sweets and desserts, well water and pesticides you're exposed to, the more likely you are to be diagnosed with Parkinson's disease. Similarly, in midlife, the more fruits and vegetables, legumes, non-fried fish, coffee, and tea a person drinks, the less likely they are to be diagnosed with Parkinson's disease. And so what happens is in clinic, patients read a little bit about this and they say, hey, I read there are 5 studies that say the more dairy you eat, the more likely you are to be diagnosed with Parkinson's. Should I stop eating dairy? People will come in and say, I read that green tea protects against Parkinson's disease. I've just been diagnosed. Should I start drinking green tea? And the correct answer is we don't know. All of the research that we have historically done on diet in Parkinson's disease looks at who goes on to get diagnosed with Parkinson's. And while these are really powerful studies that point us in the right direction, they don't do much to help the person who's just been diagnosed, because we don't have a body of evidence that says what you eat matters from the point of diagnosis forward. So that was what I set out to do. As we've also talked about so far today, is that the diagnosis occurs late. By the time you get a diagnosis, you've already had this disease for 10, maybe 20 years. And so that also makes this whole topic a little bit fuzzier, because that which prevents diagnosis may actually also treat disease progression. And so the whole point of diagnosis is a little more arbitrary. The point at which you get enough of a motor symptoms or enough of a tremor to get you diagnosed isn't necessarily reflective of this continuum that the patient is actually experiencing. So I'm going to talk about diet from a couple different angles. There's diet and Parkinson's symptoms, motor and non-motor, and diet as it pertains to the rate of Parkinson's disease progression. Most of you are a little spoiled in that you are used to being able to take a medicine and 30, 45 minutes later, feel your symptoms get better. That is what you think of when you think of symptom improvement. And that's not really what diet does. You can't go eat broccoli and watch your rigidity improve a half hour later. You can't eat a salad or fish and see your tremor go away. So I don't want you to think of diet and motor symptoms as what we're even trying to accomplish here. That's not really the goal. If diet is going to do anything, it's probably going to do more along the lines of non-motor symptoms and disease progression. So that's how we've set up the studies moving forward. But before we get into that, I just want to say that there are some ways that diet really does affect motor symptoms, and I think it needs to be addressed before we move on. Probably the most important one is that levodopa, L-dopa is essentially an amino acid that is taken up by your amino acid receptors in your stomach. Protein is just a string of amino acids. So anytime you eat dietary protein, and it can be healthy proteins, it can be plant-based, vegetarian proteins, any dietary protein can interfere with your levodopa working. I hope that when all of you were originally prescribed levodopa, as your physician was writing out the prescription, he or she said, be sure to take this medicine at least 30 minutes before or a couple hours after a protein-containing meal. That's been fairly well known for a while. But what I want to say is that sometimes an hour or two after a protein-containing meal is not enough. It takes a lot longer to digest animal products than it does plant-based products. So the protein that you find in quinoa or hummus or something like that does tend to move through you fairly quickly, and an hour after a meal should be long enough. If you are constipated or have low stomach acid, or you're eating animal products, which take notably longer to move through your intestinal tract, that duration of interaction, the time that your meds might not work, is going to be a lot longer. I've had patients tell me red meat at dinner, their meds don't work so well the next morning. So each one of you has to kind of figure out how long is long enough, what foods you can get away with. But that is probably the single biggest place where I see diet interfering with people's quality of life and medications actually working. One little hack, I don't want people working for their medications. It can be very, very stressful to figure out what time it is, when do you take your meds, what can you eat, what can't you eat. And one quality of life hack is just to save all of your protein for the evening meal. If you learn to have a bowl of oatmeal with apple and cinnamon for breakfast, or a smoothie, for lunch you have a big salad or dolmas or things that are low in protein, rice and veggies, and save your protein for the evening meal, what that can do is just free up a lot of brain power where you're not constantly doing math all day. You can just go about your day knowing that after you eat your dinner meal, your meds might not work so well, but for most people that's more acceptable because they're just home reading or watching TV or things like that. They want to save their good hours for during the day. I'm not going to get into dietary supplements, but I think this is just a really important thing to touch on, is that levodopa does interfere with your body's ability to utilize and absorb folic acid, folate, and B12. And that will raise your homocysteine levels. The longer you've been on levodopa and the more levodopa you take, the higher your homocysteine levels. And high homocysteine has been associated with worse outcomes in Parkinson's. I am a huge fan of levodopa. I want all of my patients on levodopa. I prescribe it daily. But I do feel that anybody who is on levodopa needs to have an annual blood level of homocysteine checked so that you know whether or not you need a B12 or folate supplement. You can have your cake and eat it too. I just want to make sure that you know that that is, in terms of nutritional adequacy, something that I think is a really important thing to touch on. And then there are a couple supplement things. CDP choline is an over-the-counter supplement that has been shown to make your levodopa work better, last longer. It takes a month for it to build up, but it's very effective. And similarly, people with Parkinson's disease don't have as much stomach acid as usual. About 58% of people with Parkinson's have a hypochlorhydria, insufficient production of stomach acid, and that can not only interfere with your body's ability to absorb the nutrients from food, but it can interfere with your meds working. And so if you take your levodopa with 30 mils of lemon juice or 500 milligrams of powdered vitamin C, one of those little vitamin C packets, you will get the more levodopa out of each dose. So that's a neat little way to make your meds work better with diet. So what I really kind of want to emphasize is where I think the greatest potential for dietary modification in Parkinson's outcomes is in non-motor symptoms. There are some diets like ketogenic diets that seem to do both. There was a very, very small study, I think 5 people for 1 month, that showed that a ketogenic diet improved motor symptoms. For those of you not familiar with a ketogenic diet, it's a very low carbohydrate diet. And after a few days of avoiding carbohydrates, what will happen is your body will kind of kick over to this alternative fuel source, which runs actually much more efficiently. It looks like ketones have some neuroprotective properties and might be very, very good for the brain. So a follow-up study looked at a ketogenic diet in people with Parkinson's, I believe, for about 8 weeks. And they actually showed a statistically significant improvement in the non-motor symptoms of the disease, specifically fewer urinary symptoms, less pain, less fatigue, less daytime sleepiness, and improvements in cognitive function. So while that is exciting, I want to say it's not something I use very often in clinic. One, it's very restrictive. As I told you, it's really already too difficult for people with Parkinson's to be balancing when they ate, when they took their medicine, how much protein is in it. Ketogenic diets tend to be very restrictive and not very sustainable because they interfere with quality of life. It's hard to go to eat with and find a ketone-friendly diet. It's hard to share meals with loved ones. The other reason I'm not a huge fan of ketogenic diets is they tend to increase weight loss and decrease appetite, which are 2 major problems people with Parkinson's already deal with. I don't need any of my patients having less appetite or more weight loss. So while I'm hopeful about the biochemistry and what we're learning from ketogenic diet studies, I don't believe ketogenic diets are going to be the solution in Parkinson's disease. Where I do think we're going to see benefit is in the non-motor symptoms. When we just look at the general population, we know that elderly people are at higher risk of malnutrition. People who live alone are at greater risk of malnutrition, and specifically people who have Parkinson's disease are at greater risk of malnutrition. We're not fully sure why. It might have something to do with apathy. It may have something to do with swallowing, depression, lack of appetite, anorexia, and it could have something to do with malabsorption. You could be eating the right foods, but not actually absorbing them. Malnutrition is very common in Parkinson's disease. Depending on what study you look at, between 25 and 75% of people with Parkinson's meet criteria for being malnourished. And what we see is that malnourished people with Parkinson's are more likely to be constipated, depressed, have anxiety, apathy, cognitive impairment, and dystonia or muscle pain. So this is something that we really, really need to focus on. In our own research, you'll see what scale we're using in a minute, but in our own research, our data suggests that about 2/3 of the symptoms that people have at diagnosis and throughout their entire Parkinson's journey, about 2/3 of their symptoms are actually non-motor symptoms, not the motor symptoms that have historically got all the attention. So this is what you all really want to know. Does diet affect Parkinson's progression? Does it matter what I eat? And as I told you, the correct answer has always been, we don't know, we've never looked. And so about 10 years ago, I set out to answer the question. Among people with Parkinson's, this is where we go from traditional epidemiology to something called clinical epidemiology. The study starts with the day of diagnosis. What I'm trying to answer is from the day of diagnosis forward, does what you put in your body shape the rate of Parkinson's disease progression. So we started this study, CAM, CARE, and PD. We are still recruiting. I would love anybody watching this video to please consider joining the study. Everything you might want to know about it is on the website. But we set out to do just that, find as many people as we could from as many countries, as many diverse backgrounds, as many different income classes and genders and ethnicities, and see if we could find describe what people were eating, describe how they were doing, and ask the question, can we find the people who are doing unusually well, and are they eating something different than the people who are progressing faster? Couple problems we ran into is we don't have a really good measure of Parkinson's disease severity. The tests that we use in the office aren't really good measures. They do a disservice to assessing non-motor symptoms of Parkinson's. So we needed a survey that people could complete from anywhere in the world, and it would capture both motor and non-motor symptoms. So we built a scale called the ProPD. The URL is down at the bottom on the left. You can go for free and get your own scores and see kind of how your score is today, how it compares to other people diagnosed the same time you were. But the way the scale is set up is we have 33 very common symptoms of Parkinson's disease. And we ask, on average, over the last 7 days, how severe have any of these symptoms been? If you don't have the symptom at all, you move the tab as far to the left as you can. If the symptoms are severe, and the more severe the symptoms, the further to the right you move the tab. It takes about 5 minutes, and patients will just kind of go through and rate over the past week the severity of their symptoms. What we have learned is that the average person at diagnosis has a score of about 580 and is progressing at about 40 points per year. So I want to draw your attention to the diversity. There is a tremendous amount of heterogeneity here. All of those green dots are real people on the day they enrolled in this study. There are some people who are in excellent shape 15, 20 years after diagnosis. There are other people who are in horrible shape in the first 5 years after diagnosis. And for traditional researchers, this has been a huge barrier to us being able to get studies done. We have to enroll thousands of people to be able to drown out some of that background noise. What I wanted to do is see if we could use that diversity to our advantage. Before I dive in, I just want to point out the difference between how providers historically have described Parkinson's disease and what the patient experiences. If you ask a neurologist, what is Parkinson's? You are likely to hear things like tremor, rigidity, and slowness as the defining characteristics. When we surveyed 2,000 people with Parkinson's and asked them to describe their symptoms, the leading symptoms were fatigue, impaired handwriting, loss of smell, memory impairment, and muscle pain. So this says 1,000 people. We now have 2,500 people in this data set, and these numbers have not changed much. So the study continues to grow. So this is what I set out to do. Can we find the people who are doing unusually well, the people who are doing unusually poorly, and describe lifestyle choices they may be making that might have something to do with shaping how they got into those circles in the first place? Association does not mean causation. I am not here to tell you that these behaviors cause one's disease to progress faster or slower. What we did is we looked at the people who are doing unusually well and learned, and we described their diets, and we looked at the people doing poorly and we're describing their diets. As more and more people enroll in the study, we will be able to tell you if people who switch from cheeseburgers and milkshakes start eating salmon and broccoli, does that change the rate of progression? This study, in time, with enough of you enrolling, will be able to give us some of those answers. But for right now, we only have enough data to be able to describe the success stories and the people who are doing unusually poorly. So this was our first publication using this data set. It's open access. You can find it online, a role of diet and nutritional supplements in Parkinson's disease. But what we have continued to do as more and more people enroll is we update these data every year. And so all of the updated data can always be found at this website, livinghealthywithparkinsons.com. On this website, you will not only find the cheat sheet for food, you will see our research on social health and exercise, things like that. So this is a good resource just for you to know about. But before we go on to which foods to eat, I want to stress that how you eat may be as important as what you eat. Of all of the hundreds of variables that we are looking at, people who are financially insecure and lonely are doing worse across the board every step of the way than anybody else. And so we like to think that our meds are the answer, this supplement is the answer, this food is the answer. If I just exercise, that's the answer. But as a champion of public health, I just need to take a minute to say that we have to address financial inequality, food scarcity, and some of these bigger, messier, more difficult topics if we're really going to get at the roots of some of these symptoms that we're seeing. So of everything that we see on the data, in our data set, the people who are doing the worst are the people who find it difficult to afford groceries and healthy food. To the positive, people who report cooking most of their own meals, routinely preparing meals for others, people who avoid artificial sweeteners, colors, and flavors, people who try to eat organically grown foods when possible, and people who buy from local farmers, co-ops, and farmers markets are all doing statistically better than people who say false to those statements. So let's break that down a little bit. This is another example of, we have maybe a dozen studies that say pesticide exposure increases your risk of Parkinson's disease. So people come to my office saying, should I eat organic? And so this is why this question is even on here in the first place. And the reason I want to bring your attention to it is I am not comparing people to who are pristine. I'm not saying people who always eat organic versus never. What I just asked was a true-false statement where people responded to the statement, I try to eat organically grown foods when possible. And that's really what's important to me. I'm trying to capture something that's realistic. When you're standing at the grocery store and you have your choice of organic strawberries or inorganic strawberries, are they available? Can you afford it? Are you putting in the effort when possible? And when we phrase the sentence that way, the answer was yes. We could notice a statistically better, fewer Parkinson's symptoms in those people who try when possible. There are lots of different ways to look at these, how to present these data. We've struggled a lot with kind of how to make this visually palatable, pun intended, to you. This is the chart that I like best. I'm going to flip it over on the next slide just so it's a little bit easier to read. But these are the foods that are associated with fewer or more symptoms over time. This is what everybody wants to talk about. So what we see here is that the more fresh fruits, fresh vegetables, nuts and seeds, non-fried fish, wine, olive oil, coconut oil, fresh herbs a person eats, the fewer symptoms they have. Conversely, the more canned fruits and canned vegetables, soda, especially diet soda, fried foods, dairy, specifically ice cream, yogurt, milk, and cheese, canned vegetables, beef, pork, and chicken, and drinking out of plastic bottles a person consumes, the greater their symptom severity over time. There are going to be a lot of questions that come up around here, and people want to know why. And this is where it gets a little complicated, and this is not what the study was designed to answer. I don't really care a whole bunch why. The example I like to use is that 3 million people died of scurvy, and for 200 years, we treated scurvy with limes successfully before we discovered the vitamin C molecule. And so what I want to avoid happening here in the Parkinson's community is where we wait to discover vitamin C before we start using limes. I'm a scientist. I am eager as much as anyone else to find out the mechanism of action for any of these things. But for right now, given the state of the science, I just wanted to step back and ask a very simple question. Who are the success stories? Who are the people who have your same diagnosis? And what are they doing that's different than what you might be doing? And if you start mimicking them, will you get better results over time too? It's called the positive deviance model. So what I did is there have been several studies, different designs, different cohorts, different populations, different countries that look at the foods that people eat over time and their risk of mostly being diagnosed with Parkinson's. And so what I did, where we see positive findings are Mediterranean diet, MIND diet, and ketogenic diet have a little bit of data suggesting that they offer something protective to people with Parkinson's. And so you can see, I called the diet that I'm talking about here from our patient-reported outcome study, the PRO diet. But you can see some trends between the other diets that look like they may have something to offer and the data that we're finding in our own study. In common, we have vegetables, fruits, nuts and seeds, seafood, wine, coconut oil, and olive oil. Those are pretty common across the board. Down at the bottom, you can see foods that are common negatively, on the negative side of the scale, across those diets. Red meat, pork, and chicken are pretty universally considered, better avoid them. Dairy is the tough one. Dairy is the one that is a little controversial between, some people think as long as it's low fat, it's fine. As long as it's organic, it's fine. I don't know what the answer is. All I know is that very consistently there are data, whether we're looking at motor symptoms, non-motor symptoms, longitudinal data, cross-sectional data, dairy consumption seems to be associated with worse outcomes over time following diagnosis. And that matches the traditional epidemiologic research where we have 5 other studies that say the more dairy somebody eats in midlife, the more likely they are to develop Parkinson's. I don't know why. There are some ideas that dairy decreases your uric acid levels and that a very powerful antioxidant in the central nervous system. Some people think there may be pesticides in dairy. Some people think that we're introducing the microbiome of cows into the human intestinal tract, and that might be part of the problem. It could be lactose intolerance. With age, many people become lactose intolerant, and it could be this chronic low level of inflammation. We don't know what it is, but I'll say the 2 most common questions I get are, can I find me a way to be able to continue to eat ice cream and cheese in spite of your data? And the wine question, everybody wants to know red wine or white wine, and we don't know. We don't have enough people enrolled in the study yet to be able to answer that question. So as I've said, association does not mean causation. I cannot promise you that if you go home and change your diet, that your disease outcomes will be better. There's something called confounding. It might not be that broccoli is doing anything for you. It could be that the people who eat the most broccoli and Brussels sprouts in shopping at farmers markets are also the people who exercise and have more friends and get a better night's sleep. So this may not be that the food itself is responsible for the change, but it represents a lifestyle that is associated with better outcomes over time. So you all have to make a decision. How much data do you need before you take action? Are you going to wait for a double-blind randomized placebo-controlled trial? Someone to design placebo salad, placebo salmon, placebo cheeseburgers, and you won't know what you're eating. I mean, it's just not feasible to do a double-blind placebo-controlled trial of diet and Parkinson's disease progression. So if you're going to wait for level 1 evidence, I think you're going to be waiting a very, very long time. So you all have to decide, how much do you believe these data? How gung-ho are you going to get? How disciplined are you going to be? Should you encourage these foods on the left? Should you avoid the foods on the right? And I would encourage you to all kind of think about the consequences. What are the consequences of trading out your ice cream for sorbet? What are the consequences of you trading out your butter for olive oil? Back to this original idea of what are you trying to do? What are the risks? What are the benefits? How much does this cost? How inconvenient is it? All of these things have consequences, and food is not just about nourishment. It's social. If you've got a bunch of teenagers in the house who refuse to eat the foods on the left, but you want to do it for your right, those are stressors that come into play. But what I will say is that the foods on the left are also the foods that seem to be protective against cardiovascular disease, Alzheimer's disease. They're looking to be protective against Parkinson's disease progression. And so you may actually find that the side effects of this sort of intervention are actually positive. They may actually increase your health over time. So as we talked about, this red line looks at what you would expect to see in terms of Parkinson's disease progression if we decreased your symptoms. The slope is the same. The disease continues to progress, but at each step of the way, the symptoms are a bit less. That's nice. This is what the dopaminergic medications offer us. It's great. It does make a big difference over time. This is what delayed progression looks like. This is what a 50% reduction in slope looks like. And you can see here how the earlier you get started, the more impact it has over time. So if you are young and you plan and want to live for a long time, this is probably a more important topic for you than if you are 99 years old today. And in a dream world, this is what I think of as integrative medicine. This is where we get your pharmaceutical medicines optimized, we get you on dopamine, we get your symptoms under control, we use diet to clear the way to make sure the meds are working well, and then we use some exercise and dietary modification to actually decrease the slope of progression. And you can see that over the next 25, 30 years, this translates to really tremendously meaningful impacts to the patients affected. So with that, I just want to say thank you again for the invitation to be here.